Chang, thank you for joining us. I am very excited to welcome our speaker today, Dr. Chris Pannucci. He used to be faculty at University of Utah. For those who don't know, he has now transitioned into a private practice in Spokane, Washington, where he is still doing the gamut of reconstructive complex surgeries. And he has published a lot of great, useful papers that we will put up as links through today's talk about VTE and specifically plastic surgery, because I know that's something prior to a lot of your work was really not published in the literature much. So thank you so much for being with us today. And I'm going to remind everybody, if you have questions, please submit them at the bottom on the chat feature. We will hold them till the end, and Dr. Pannucci has graciously agreed to stay to answer as many questions as we can.
Great. Angela, can you see my screen now? I took you out.
You are good to go.
Fantastic. Well, first of all, thank you Angela, for this unique and exceptional opportunity to give an invited webinar in the setting of a global pandemic. There's 270, I think, surgeons that are currently logged in, with probably more to come, really representing an international community, which is just amazing. Certainly Dr. Nahai, Phaedra Kress, the ASJ, and Angela, thank you for putting all this together. It's a great resource for all of us who are looking to become better educated as plastic surgeons during COVID-19. For the past 14 years now, it's been my distinct privilege to really be on the forefront of what has been a specialty-wide effort to better understand venous thromboembolism and how it impacts our patients. I will hope in the next hour to really share with you sort of a condensed version that you can take home and use on an everyday basis. Before I get too far in the weeds though, a few disclosures. I don't think that any of these are directly relevant to this talk, but in the midst of full disclosure, I will say that the Chest Foundation is the research arm of the American College of Chest Physicians, which writes and rewrites the guidelines that are used certainly in North America. The Chest Foundation has funded my research in anoxaparin metabolism in thoracic surgery patients with direct research funds of $30,000 in the last 12 months for a grant that's now complete. In addition, in an unrelated grant, Mentor, a Johnson & Johnson company, has funded me for a study looking at breast implants and chest wall trauma. In addition, I am a board member of the ASERF, and I am also on the editorial board of the ASJ. I think that this picture really encapsulates what I want to convince you of today. What works for one does not work for all, is clearly shown by this photo of 11 or 12 people all trying on the same suit. You can see that for some people that suit is too much, for some it's too little, but in only one case is it truly a one-size-fits-all approach. I would argue, and I hope that I'll convince you today, that your approach to venous thromboembolism will be similar, that your patients are not the same with regards to VTE risk. So one of my number one goals today is really to help you to understand that VTE prevention is not just a yes or no to providing chemical prophylaxis. In fact, being thoughtful in your approach to VTE and starting that thoughtfulness even in the preoperative consultation can allow you to really initiate a comprehensive approach to risk factor identification as well as modification for plastic and aesthetic surgery patients. For some perspective, pulmonary embolism just in the United States is believed to be the causative factor for 100,000 deaths in the United States alone every single year. And that may or may not be enough perspective for you, but when you put it in the larger perspective, pulmonary embolism in this country kills more people than the combination of car accidents and breast cancer. And ironically, it's a problem that many of your patients have probably never heard of. Plastic surgery has an evolving amount of literature on VTE, and it's now been studied fairly extensively with a special emphasis in the last 10 to 15 years. we know that amongst the overall inpatient population, there's about a 1 in 60 or 1 in 70 patients will have a venous thromboembolism event, about 1.5%. Now, interestingly, when you use individualized risk stratification, you actually find that there's a huge range amongst that inpatient group. There's low-risk people whose expected risk is well below 1%, and there's high-risk people whose risk exceeds 10%. Those numbers are different, but similar trend amongst the outpatient and aesthetic population. Overall, we know pretty well that the ambulatory surgery plastics population has about a 1 in 1,000 risk for venous thromboembolism. And that ranges by procedure. Breast augmentation is about 1 in 1,000. Combined breast and body procedures can increase your risk. Some have reported abdominoplasty patients have a risk as high as 1.4%, disturbingly similar to the baseline risk amongst inpatients. And while we don't screen everyone, if you do screen everyone with ultrasound, you actually find that in the all-cause aesthetic population, about 1% has an asymptomatic clot. A little closer to home for us as surgeons, when you think not of the patient experience, but the surgeon experience, it's disturbing for sure. When you ask surgeons who do various types of plastic surgery, have you personally had a patient die? Between 4 and 7% of surgeons over the course of their career have personally lost a patient to pulmonary embolus. And that number, unfortunately, has remained fairly consistent over the last 10 to 15 years. On a couple of different occasions, I've written CME articles trying to provide the bigger picture of venous thromboembolism in plastic surgery and provide a practical use or safety guide for surgeons. This one, which was geared more toward inpatients, was published in PRS in 2016. And this one, which Dr. Nahai had asked me to write, was published in the ASJ in 2018. And this article in particular, I believe that Phaedra is going to be somehow sharing a PDF of this for everybody, because this article is would be a great one if you're going to take one thing away and read it, and maybe even print some of the figures and have them on the wall of your clinic. This is a great one, and I'll show you that on this next slide. My general approach in 2020 to venous thromboembolism in the aesthetics population uses this idea of 4 pillars or 4 different opportunities to identify and modify VTE risk. And this is a figure that's taken directly from that ASJ CME article. Like I said in the beginning, I hope to convince you that venous thromboembolism is more than a binary decision, do I give an anticoagulant or not? And using this approach, you, I hope, will appreciate that there are multiple opportunities in your patient's care pathway that you can identify, modify, and minimize risk for clots. So let's start with the preoperative time point. For the preoperative time point, there are multiple things that you can do either at your initial consultation or from the initial consultation until the patient comes on the day of surgery to identify venous thromboembolism risk. First thing we should talk about is individualized VTE risk stratification. This is a practice that is now formally advocated by the American Society of Plastic Surgeons based on their 2011 consensus panel, and also the American Association of Plastic Surgeons based on their 2016 systematic review and consensus conference. The form that individualized risk stratification is recommended to take is using this, which is the 2005 Caprini score. The Caprini score is the most widely utilized and well-validated risk prediction tool in plastic surgery patients, but also in surgical patients as a whole. What it does is it creates a individualized patient-centric risk score based on the presence or absence of about 40 risk factors. And certainly you would look at this and say, oh, well, a lot of these risk factors are not relevant in aesthetics, and that's okay. What's important is that your patient may, by this score, identify risk factors that you otherwise wouldn't thought about. And it's a thoughtful and checklist-driven way that you can identify these risk factors. Now, the aggregate score definitely works to predict risk in plastic surgery patients. This is a bar graph looking at 60-day symptomatic venous thromboembolism in 1,100 plastic surgery inpatients. And you can see that while the overall rates, if you take the rate of VTE in plastic surgery patients in the hospital, is about 1.2%, you can see that nested within that group, there's a larger variation in risk. You can find plastic surgery patients whose risk as an inpatient is as low as less than 1% or as high as 11%. And I would argue that understanding and knowing about this 15-fold variation in risk in advance would be helpful for you to make decisions. The Caprini score is not just something that exists in the plastic surgery population. In fact, the 2005 Caprini score has now been validated extensively in surgical patients as a whole. So whether it's in general surgery, vascular, urology, gynonc, SICU, head and neck, the Caprini score works to identify a 12 to 20-fold variation in VTE risk amongst the overall surgical population. And this is actionable information because I think that most surgeons would treat patients differently if the risk for clots is less than 1% or more than 10%. In 2017, in the Annals of Surgery, we conducted and published a systematic review and meta-analysis looking at the Caprini score in surgical patients as a whole. And we found that the trends shown in individual surgical populations were exactly the same for all-cause surgery patients. In fact, for 6,100 surgery patients as a whole who received no chemical prophylaxis, you can see that there is that same about 15-fold variation in VTE risk. So data like these are why plastic surgery-centric organizations like the ASPS, the AAPS, as well as the American College of Chest Physicians explicitly advocate not only for individualized VTE risk stratification, but advocate that you do so using the 2005 Caprini score. And over time, it's not just national guidelines committees and organized organizations. It's now state-based quality initiatives, countries' official VTE prevention recommendations, and major institutions that are doing so. What about the Caprini score for aesthetics? I'm sure that many of you who do aesthetic surgery are looking at this and saying, well, my patient is very unlikely to have been in a multiple trauma situation within the last month or to have recently had a joint replaced. And I agree with you that that's true. But the Caprini score can be helpful in the aesthetic population as well. This is a study published out of Stanford looking at baseline Caprini score amongst 412 consecutive rhinoplasty patients. And this is very interesting to confirm what I think many of us understand inherently, and that is that the overwhelming majority of aesthetics patients are actually at low risk for VTE. In fact, 98% of those 412 consecutive rhinoplasty patients had Caprini scores of 6 or less. And as you'll see moving forward, that is an important cut point for whether chemical prophylaxis is impactful or not. So we're still in the preoperative setting, right? The Caprini score is something that you can complete during your initial intake or at that original clinic visit. We haven't made the decision to operate yet, and we certainly have not gotten to the operating room. Having identified patient-centric venous thromboembolism risk factors, you now have the opportunity to modify those risk factors. In fact, when you look just at the Caprini score, there are multiple risk factors that you can identify and potentially modify prior to an elective operation. Let's talk about a couple of these. And ultimately, your goal is to try to tip the risk-benefit scale in your favor. If you identify someone who's at a higher level of risk and you find risk factors you can eliminate, you can tip the scales in your and the patient's favor. So operating room time represents a modifiable risk factor for venous thromboembolism. John Kim is a plastic surgeon at Northwestern, and he published this great study looking at 1.4 million surgical patients in the NSQIP database. What John Kim showed is that no matter what type of surgery you perform, the trend is the same. there's essentially a linear relationship between time spent in the operating room and your risk for venous thromboembolism. This was also shown in a slightly different way by Julian Winocour, looking at Cosmetic data. Julian looked at 129,000 aesthetic surgery patients in the Cosmetic database and clearly showed that when you combine procedures, and this is really a proxy for time spent in the operating room, when you combine procedures, you do increase risk, and you do so by a factor of 5. But to be fair, your actual risk increase is about 0.16%. And looking a little deeper, they showed that there's more of almost a logarithmic appearance to the risk as you add procedures. So as you go from 1 to 2 to 3 to 4 procedures, your risk increases more logarithmically than linearly. In addition to time spent in the operating room, another opportunity to modify VTE risk is estrogen use. Dennis Valente, who's in Brazil, had published this study of 1,200 aesthetics patients and clearly demonstrated that use of hormones, including estrogen, around the time of your aesthetic surgery is a significant predictor of developing downstream venous thromboembolism. It's interesting, though, that in this ASJ article, Chada and colleagues surveyed aesthetic surgeons to say, well, what are you doing about estrogen products? And amongst 220 aesthetic surgeons, the majority, in fact, 2/3, did not routinely discontinue oral contraceptives at the time of an aesthetic surgery. And amongst the 1/3 of surgeons who did, a minority did so preoperatively only, and more did both pre and postoperatively. It's interesting, though, that since aesthetics patients are at a low baseline risk for clots, taking away estrogen products probably decreases their risk by a fraction of 1% and does put them at increased risk for example, pregnancy. In the gender affirming community, taking patients off of estrogen also increases their risk for gender dysphoria, leading some surgeons to say, well, in the absence of other VTE risk factors, really surgeons can have an educated discussion with their patients about the risks and benefits of taking them off of their estrogens. Plastic surgery tourism is a sort of underappreciated risk factor for venous thromboembolism, and I certainly hope that all of your aesthetic practices are busy enough that people are routinely flying to see you. Something that you should know is this study. It was actually a series of studies called the Lawnflit studies, and some industrious researchers rolled a duplex ultrasound scanner into the waiting area at Los Angeles International Airport. And they went to the holding area for flights that were going across the Pacific to Asia and Australia. They scanned people, asymptomatic people, getting on that flight and showed, yep, getting on the flight, you do not have a clot. They then did a duplex ultrasound 12 hours later when they got off of that flight and found that 4.5% of people developed a deep vein thrombosis that had no symptoms during that flight. In a subsequent study, they randomly assigned long-haul travelers to wearing compression stockings or not, and they found that you can decrease your risk for asymptomatic deep venous thrombosis from 4.5% with no stockings to 1/4% with stockings. So if you have people flying to see you, wearing compression stockings is a low-risk way that you can decrease their risk for clots. We're still in the preoperative setting. We still have not even gotten to the operating room. Identifying patient-level VTE risk provides you with the opportunity to send someone for a hematology referral if you think that it's appropriate. For me, I think that hematology referrals can be considered when you identify people with a certain group of risk factors. These risk factors in the lower left look at family history of clots, look at known genetic hypercoagulable states, and can help you to identify, is someone genetically predisposed to clotting that maybe you would want some additional input. This risk factor, which is difficult to talk about, but is important to incorporate into your conversation, many times women with a known genetic hypercoagulable state who haven't personally had a clot have multiple lost pregnancies as a manifestation of that. And so if you meet with a woman and they've had 2 children but 5 pregnancies, this would be something to consider, that they may have an unrecognized genetic hypercoagulability. And finally, we're still in the preoperative area, but working on the patient-physician interaction. You are now learning a lot about this patient. You are now able to intelligently provide a percentage-based risk to them, and you can have a more informed conversation with your patient about the risks and benefits of surgery. You can also make sure that you are providing them with opportunities and discussion about how you can modify their risk, and also decision points that you can make. For example, if someone wants to have 4 procedures over one 8-hour session, you can talk with them about the risk of combined procedures, the risk of more lengthy time in the operating room, and how that impacts their risk for clots. And ultimately make a decision with the patient. Is this a reasonable choice? Should we move forward with this elective procedure? It also helps from the documentation and informed consent perspective, that you can use an individualized risk calculator to try and provide a percentage-based risk, and also document to both the patient's conversation and in your chart that you are being thoughtful and careful with regards to risk for clots. So everything that we've talked about just so far is in that first column, thinking about you in the office with your patient. We're now moving to the operating room and thinking, being thoughtful about what we can do during an operation to minimize a patient's risk for clots. So intraoperatively, I'd like to talk about the role of non-general anesthetic, if it's possible. This is actually a data-driven recommendation, and the AAPS in 2016 was able to pool data from several papers and very convincingly show that non-general anesthetic is protective against venous thromboembolism when compared to a general anesthetic. And in fact, they made their strongest recommendation of the whole paper, which was a grade 1C recommendation, that they recommended when it's available. Certainly there are surgeries that you cannot use a non-general anesthetic for, but when possible, surgeons can at least consider using a non-general anesthetic to minimize patients' risk for clots. So for a lower extremity procedure, if you have the capacity to do it under an epidural or a femoral nerve block, or if you have a breast anesthesiologist that can do blocks as plus local as opposed to a general, those would both be opportunities to use this technique. Intermittent pneumatic compression is something that I think that we all know about. Elastic compression stockings are relevant here, but they are not the same as intermittent pneumatic compression. Elastic compression stockings are the knee-high compression stockings that will preferentially keep blood from pooling in the superficial system, will utilize those superficial to deep connections to shunt blood to the deep system, where it can then return from the feet up to the head. In this meta-analysis performed by the Cochrane Group, the sort of recognized world leader in meta-analyses, they identified surgery patients who had graduated compression stockings applied the day before surgery or at the time of surgery and kept until fully ambulatory. I'll be showing more meta-analyses, and so you know, if you haven't seen them before, the vertical line in the center is the line of no effect. When a diamond, the aggregate effect diamond is the diamond that I'm pointing out with the arrow here, when that diamond does not touch the line, you know that the difference was significant. So here you can see that this meta-analysis of elastic compression stockings versus not clearly shows that they prevent deep vein thrombosis. In fact, they did so at a rate of 13% of people with graduated compression stockings had an asymptomatic clot by radioactive iodine study, and twice as many, about 1 patient in 4, had a clot without stockings. So intermittent pneumatic compressions are an active way to clear blood from the lower extremities. Graduated compression stockings are more passive. Now, the intermittent pneumatic compressions work, we believe, in 2 ways. One of them is that they physically squeeze the calves to propel the blood from caudal to cranial, and therefore preventing stasis and venous dilation. It's also believed that intermittent pneumatic compression can activate the local fibrinolytic system, producing a low level of anticoagulant effect. Now, there's two studies that I'm aware of that have looked at this, and they had different results. One study looked at, actually both studies looked at tissue plasminogen activator and Pi1 levels, and they showed that sequential compression devices may or may not have an effect on those levels. No matter how it works, we know that the end result is that they do work. From an actual clinical impact perspective, there's been wonderful meta-analyses performed looking at the role of sequential compression devices to prevent deep vein thrombosis. This is again another forest plot that clearly shows that the aggregate effect diamond at the bottom is to the left of the line of no effect, that these prevent clots. And based on these data, again, the AAPS systematic 3 meta-analysis recommended that intermittent pneumatic compression should be used to prevent VTE in plastic surgery patients. In the operating room, you as a surgeon have the ability to balance your wish and the patient's wish to perform multiple procedures in one setting with their risk for clots. This is a paper that Phil Hake, when he was the ASPS president, wrote in 2009 as part of a larger patient safety series. And in that, they talked about trying to limit elective surgery to 6 hours or less. I looked into this and I wasn't able to find any data that support 6 hours as the clear binary cut point. But they're making this 6-hour time point, I believe, in reference, for example, to John Kim's paper, which showed that the longer you spend in the operating room, the more likely you are to develop a clot. I think they're also making that recommendation based on Julian Winnicor's Cosmetic data that clearly shows there's a increased risk for venous thromboembolism when you perform combined procedures. This has also been shown by Amy Alderman, who looked at complication rates in breast augmentation. And she showed that for breast augmentation patients having a single procedure, their risk for DVT at 30 days was 0.02%. Adding additional procedures increased that risk by a factor of 5, 2.1%. And so you can see, yes, there's a 5-fold increase in risk, but the actual risk increase is a fraction of 1%. And in my mind, that really makes it important for you to understand talking with patients about this, because if you tell patients your risk for clots is going to go up by a factor of 5, or your risk for clots is going to go up by a fraction of 1%, both are true. And that's full disclosure for them. But providing them with the numbers as best you can allow them to make an educated decision about their own level of risk tolerance and balancing that with the desire to have multiple things done at once. Specific to the abdominoplasty population, abdominal wallplication is an intraoperative maneuver that definitely increases risk for venous thromboembolism. This has been studied in at least 2 different series of abdominoplasty patients, and as well multiple series of abdominal-based breast reconstruction that takes the fascia. What those studies show is that plication, when you do it, does significantly increase intra-abdominal pressure. For abdominoplasty patients, it increases the intra-abdominal pressure by about 6 millimeters of mercury. For patients having a pedicled tram flap with fascial harvest, it does so by about 12 millimeters of mercury. Certainly neither of these are creating a situation of intra-abdominal catastrophe or hypertension, but they do increase the intra-abdominal pressure. So what does that do? Well, Arash Momeni, who's on faculty at Stanford now, looked at this in belly-based breast reconstruction patients when he was at the University of Pennsylvania. And specifically, they looked at 18 consecutive free flat breast patients who had fascia taken between 2 and 2.5 centimeters at the time of their surgery. So this is analogous to plication because you're tightening the abdominal wall and the closure. It's interesting that they looked at the black line is the mean diameter of the common femoral vein. And what you can see in this graph is that between the pre-op area and the PACU, the mean common femoral diameter went up, increased, indicating that there was some upstream restriction to flow. the plication that occurred. And that risk continued, or the pressure continued to increase from PACU to post-op day number 1. So clearly, when you tighten the abdominal wall fascia, that small change in intra-abdominal pressure can put a back pressure on the common femoral vein, creating lower extremity stasis, which is a recognized risk factor for clots. And as a control group is that light gray bar. They did look at the internal jugular vein and showed that no, this was not a factor of fluid resuscitation in the operating room, for example, because the internal jugular vein did not show the same dynamics. It was interesting that they showed when you mitigate the effect of plication using a bridged mesh repair of the abdominal wall, this is the dark black line, that you can improve your common femoral vein flow as opposed to primary fascial closure. So I present all this information, and some of you may be shaking your head saying, is he really saying that I should never do a combined procedure? Is he saying I should never plicate? Well, no, I'm not saying that. You can absolutely combine procedures safely. You can absolutely plicate the abdomen when it's necessary. And this really gets back to that patient-physician interaction. You having an educated discussion with your patient, talking about the risks and benefits of things you're planning to do in the operating room. Specific to these questions, you know, I understand that plication is a important and even necessary part of the aesthetic abdominoplasty, and I am by no means saying you should not plicate. But perhaps for a massive weight loss patient or a male who doesn't need that plication, maybe you shouldn't be doing it as a matter of course in someone who it won't make as big of an impact. So we're now moving out of the operating room and we're getting to the PACU. Just that brief transition, even in that 2 or 3 hour stay in the PACU, there are still things that you can be doing right after the surgery to do your best to minimize your patient's risk for venous thromboembolism. So we'll talk about some of those. Early ambulation. I know that we all talk about early ambulation, but it certainly makes sense. We know that the calf muscle pump matters, and specifically that the calf muscle pump impacts the stasis, which is a critical component of Virchow's triad, one of the 3 known factors of why clots develop. So getting people up and walking can make their own calf muscle pumps work, can minimize lower extremity stasis, and while it would be difficult because it would be a study that would require, honestly, tens of thousands of patients to prove, there's really no reason not to get someone up and walking early. Avoiding dehydration, I think, is a similarly low-risk adjunct to minimizing clot risk. There's only one paper that I found that looked at the relevance of postoperative hydration to prevent deep vein thrombosis. John Kiter is a plastic surgeon, now retired, I believe, in Salt Lake, and he looked at a series of 450 consecutive abdominoplasty patients. Now, he routinely admitted people overnight, but since he was admitting people, he took that opportunity to titrate their intravenous fluids for a 24-hour period to a goal urine output of 30 to 50 cc's an hour. And using that hydration protocol, he had 1 symptomatic deep vein thrombosis in 450 consecutive abdominoplasties for a very low rate. Now, this is not very high quality data, but it's good data. And their conclusions, I think, were really good. Just to say that hydration and lower extremity elevation are fairly innocuous and risk-free ways that you can potentially modify and minimize your patient's risk for VTE. We talked before about intermittent pneumatic compression and how that works in the operating room. Certainly in that period where your patients are waking up from anesthesia and are not moving around, maybe not flexing their calves as much as they could be, utilizing those intermittent pneumatic compression devices in the PACU, I think, is beneficial. While there are battery-operated IPCs that I'm aware of, I would say that these type of IPCs are impossible and dangerous to try to walk in. And so certainly when your patient is up and walking, these devices, in my opinion, become redundant and unnecessary. Evaluating garments for constriction. This is a very interesting thing that has been studied in at least 2 studies that I'm aware of, looking at duplex ultrasound in patients wearing garments and not wearing garments. You can see in this study that when patients are not wearing a garment on your left versus that same patient putting on a garment and being re-ultrasounded, that you have immediate dilation of the popliteal vein. Just like I've showed before with some of those ultrasound studies by Momeni, this shows that there's an upstream restriction to flow, and that in fact may be the garment itself. These authors went a little bit farther to look at some of those garments and identify common areas where the garments can plausibly be a little bit too tight, and they recommended performing releases by cutting the garment in these tight areas. Another study, again out of Brazil, looked at this as well, and they showed that garments as well as abdominal binders can significantly increase the common femoral vein diameter with a reduction in femoral vein velocity, no matter which garment you chose. Should you not use garments? No, I'm not saying that. When you are doing large volume liposuction and the garment is necessary to achieve your postoperative result, I think that the garment is fine. But be thoughtful that an incorrectly sized garment has the potential to impact how your lower extremity veins drain. And again, this comes back to the physician-patient interaction. These are all things that you can be talking to your patients about. So we're moving now to that final column. We've made it from the preoperative setting where we've identified and tried to modify VTE risk factors to the operating room where we have tried to promote circulation by avoiding a general anesthetic, by using intermittent pneumatic compression and getting people out of the operating room as soon as possible, to the PACU where we've talked about those sort of innocuous and risk-free adjuncts of being well hydrated, early ambulation, continuing the IPCs until they're up and walking. But now people are going home. So what can we do at home? Well, we talked about ambulation and avoiding dehydration already, but it's worth mentioning them again. Having these as things on your discharge summary and or talking with your patients in advance about the need to be up and walking regularly, the need to avoid dehydration. Incidentally, people who are well hydrated have to get up to use the bathroom, so it is win-win in that regard. But these are things that I do my best to talk with my patients about because frankly, I don't see how they would hurt. We talked about compression stockings, and people might be flying to see you, but also flying or driving home. I'll remind you again that the Lawnflit study showed that people develop clots that are asymptomatic during long flights. And when I have people that are flying to see me or flying home after a surgery, I try to encourage them to wear compression stockings whenever possible. And thinking about the postoperative setting, this is the time when most of us, if we're going to use an anticoagulant based on patient-centric risks and benefits, this is the time that most of us, I believe, would start it. Now, I want to go back to one of the first slides that I presented. And one of my goals today was to try to convince everybody I just saw it ding the 334 of you currently on the webinar, that VTE prevention is more than just a yes/no to providing chemical prophylaxis. And to make that argument that I believe in that strongly, this is the 90-second slide of this talk, and I've been talking for 40 or 45 minutes. And this is the first real mention that we're going to make of using anticoagulants as a way to prevent clots. I hope that that point convinces you that there are so many other things you can do that are not involving blood thinners to minimize your patient's risk for VTE. But to talk about anticoagulants, so in the late 2000s, in about 2008, the Plastic Surgery Foundation and their clinical trials network subcommittee were involved in developing the venous thromboembolism prevention study. Now, ultimately, through the PSF's guidance and the clinical trials network leadership, and specifically the leadership of Ed Wilkins at Michigan and Andrea Pusick, who was then at Memorial Sloan Kettering, they established the VTEPS network. This was a group of 4 large volume hospitals in Regents Hospital in Minneapolis, University of Pittsburgh, Texas Southwestern, and the University of Michigan that all banded together. And their surgeons reviewed the data, and in agreeing to participate in the study, they all were agreeing that, yes, we believe that VTE is a problem in surgical inpatients, And we believe in 2008 that there was data to support that surgical inpatients should receive chemical prophylaxis or an anticoagulant. So in the end, we got, I think it was 53 surgeons on board at 4 different institutions to all sign on to a new clinical paradigm starting on January 1st, 2009. So between January 1st, 2009, and I believe we stopped accruing patients in about 2 years in 2011, those 53 surgeons routinely put all plastic surgery inpatients, patients who had had a surgery under a general anesthetic, on enoxaparin 40 once a day, and then followed them for 60 days to look at their risk for symptomatic VTE. The control group for these studies were similar patients. They also had an operation under a general anesthetic. They also were admitted after surgery. And they did so in the 2 years or so before the study commenced. And so that established a cohort of about 1,900 historic control patients, about 1,500 patients who received postoperative enoxaparin. And this is a big study, and it was, we thought, powered to look at our questions of interest. So it was very interesting to look at, first of all, I've showed you some of the VTEPS data, and those were the data that validated the Caprini score in plastic surgery patients, specifically showing that within the overall inpatient population, there's about a 15-fold variation in patients' risk for VTE. It was really interesting to see that that risk level varied substantially by Caprini score and also receipt of enoxaparin. This graph looks at the impact of enoxaparin when stratified by Caprini score. And if you're looking at this graph, you can see that enoxaparin, which is the blue bar, for low-risk patients really made no difference. It wasn't until you got to the higher risk population, Caprinis with patients with Caprini scores of 7 to 8 or greater than 8, that you can see that substantial risk reduction between 1.5% and 4.5%. Now, to be fair, the VTEP study was not originally powered to look at the endpoints stratified by Caprini score, but also there are multiple factors that impact VTE risk besides Caprini score and enoxaparin. So when you have multiple identified confounders in a large research database, the correct way to control for those is with a regression. And we did that regression. And what we showed is that when we looked at things carefully, that length of stay, baseline Caprini score, and receipt of enoxaparin were each independent and significant predictors of downstream clots. So these data really clearly showed that providing high-risk patients, those with Caprini scores of 7 to 8 or greater than 8, with enoxaparin was protective against symptomatic VTE. And it's interesting to see now that some of these data are now being independently confirmed. Just in the last few months, there was a paper out of China that specifically, out of Japan, that specifically identified that higher risk patients, Caprini 7 to 8 or greater than 8, were the ones independently associated with developing postoperative DVT. So that's, of course, only half the story. If you're providing an anticoagulant to decrease clot risk, you also want to think of how will it change bleeding. There's a few good papers out there. This was a systematic review of 33 randomized controlled trials that included about 33,000 surgery patients. These were all-cause surgery patients. All their patients received aggressive regimens of pre- and post-op prophylaxis, and they showed that the reoperation rate for bleeding occurred in less than 1% of patients. The VTEP study had bleeding data for almost 3,700 plastic surgery inpatients, and we showed that, yes, providing everybody with enoxaparin did increase their risk, and it did so by about 0.7%. That's a number needed to harm of 1 patient in 150. Statistically, that was not significant. Again, I think that it's probably real and that we were just underpowered to show it significantly. We did do a regression, and interestingly, we found that in inpatient plastic surgery, there were several identified factors which predicted bleeding risk. And they all had a common factor. Breast surgery and body contouring have a large area of undermining in a highly vascular area. Microsurgery procedures, surgeons are going to be unwilling to tolerate bleeding next to their anastomosis. But interestingly, even with that regression, receiving postoperative enoxaparin was not an independent predictor of bleeding. We looked at this in that Annals of Surgery meta-analysis as well. We looked at the role of Caprini score and chemical prophylaxis in surgery patients as a whole. It's worth noting that amongst 13 identified studies, 15,000 surgical patients, 4 of those studies were actually from plastic surgery. And these, again, are forest plots. This forest plot is limited to patients with Caprini score of 3 to 4 and 5 to 6, and clearly demonstrates that there is no demonstrable benefit to providing chemical prophylaxis in a low-risk surgery population. It's not until you get to higher risk patients, those with Caprini scores of 7 to 8 or Caprini scores of greater than 8, that you can clearly demonstrate that a significant VTE risk reduction occurs. Now, I realize some of you may have protocols at your hospitals that mandate chemical prophylaxis provision, but these are the data that support whether that is an impactful recommendation or not. In that meta-analysis, we were able to look at bleeding for 7,500 surgical patients as a whole. Again, looking at that green arrow, that's the aggregate effect diamond. In this study, we did say that, yes, indiscriminate provision of chemical prophylaxis does significantly increase bleeding. And that really makes me stop and think and say, well, if you give it to everyone and you increase bleeding, perhaps a more precise approach that thinks about patients' baseline risk would be better. Ultimately, then, from that meta-analysis, we showed that only patients with Caprini score of 7 to 8 and greater than 8 have a demonstrable VTE risk reduction from anticoagulants, and that if you indiscriminately anticoagulate everyone, you will significantly increase bleeding. So that's an interesting lead-in to the fact that, you know, I give talks on VTE at many national and international meetings, and a lot of surgeons, aesthetic surgeons, have come up to me afterward and said, listen, I don't want to do all this. I don't want to do the individual rest stratification. So my solution is I anticoagulate everyone. And surgeons give different reasons for doing that. Some people say, well, it's a safe thing to do. Some people say, I think it's effective. Some people say, I just don't want the liability of not doing it. And so I try to be over and above what I think maybe I should be doing. We can talk about all those. Well, let's talk about the data. In the early 2000s, Dernig and Jungwirth published this study, 126 consecutive facelift patients, and they used a very aggressive regimen of a preoperative dose of a low molecular weight heparin and then dosing it every 24 hours. And they had a monstrous rate of bleeding. 16% of people who got preoperative low molecular weight heparin bled, as opposed to 1.1% who didn't. And interestingly, these all bled within 10 hours before the first postoperative dose. And I think this really convinces me that for a highly vascular area like the face, preoperative anticoagulation is probably not the best strategy. This is a study published in the ASJ just recently that looked at providing enoxaparin to all abdominal body contouring patients out of Stony Brook. And you can interpret these data a few different ways. Group 1 versus Group 2 did not or did receive enoxaparin. And you could say that, yes, receiving postoperative enoxaparin increased the rate of bleeding by 1.5%. It didn't increase their risk of reoperative hematoma, and it was certainly underpowered for VTE. But some people would look at this and say, well, if you give enoxaparin to everyone, your rate of bleeding is in the low to acceptable range, somewhere in the 1 to 3% range. Galdini, who's in Brazil, tried to do a randomized control trial giving the oral 10A inhibitor rivaroxaban to 40 consecutive abdominoplasty patients. And in their paradigm, they gave both an oral 10A inhibitor and a high dose of an NSAID, which might have potentiated bleeding. But interestingly, they had 8 bleeding events by patient 27, all of which were in the rivaroxaban group. And ultimately, their data safety monitoring board asked them to stop the study, saying that the rate of bleeding was too high. That was a Brazilian study, but the oral anticoagulants have been studied in 2 American studies that I'm aware of. And interestingly, the results were not the same. This was a study by Morales and colleagues published in the ASJ in 2016, showing that the rate of hematoma with oral 10A inhibitors versus low molecular weight heparin were all less than 1.3%. And for all of those regimens, providing that medicine across the board came with a low rate of clots, somewhere between 0.5% or less. And then following that, Joe Hunstead, also in the ASJ, published their plan or their strategy of anticoagulating all abdominoplasty patients with the first prophylactic dose of an oral 10A inhibitor, ivaroxaban, given 12 hours after the operating room and continued for 7 days. They showed that with that regimen, the rate of bleeding was about 4%. About 2% of those people were returned to the operating room, and they showed that their rate of VTE was less than 1%. There's no data that say that these interventions are required, but for people that are choosing to do it across the board, these at least help you to understand the safety and effectiveness of the intervention that you're performing. Herluf Lund in St. Louis published a study looking at no anticoagulant versus fondaparinux, again in all-cause body contouring procedures, showed that they could significantly decrease rates of symptomatic venous thromboembolism and a small 0.6% but demonstrable increased risk for reoperative hematoma. So again, there's many studies out there that can help us to better understand what happens when you anticoagulate all aesthetics patients across the board. I often present these slides and people say, well, what do you think? And as I look at those data, I'm always forced to come back to this paper that again was the ASJ 412 rhinoplasty patients that showed that the 98% of rhinoplasty patients, and this is the only study that's looked at Caprini scores in aesthetics patients, 98% of rhinoplasty patients are at low risk for clots with Caprini score of 6 or less. And I think that this is probably true for other aesthetics populations as well. Based on data that we know of that only patients with Caprini score of 7 or higher have a demonstrable VTE risk decrease with anticoagulants, I think that the vast majority of aesthetic patients are at low risk for VTE and don't require chemical prophylaxis. But I acknowledge that other people have a different practice and that they anticoagulate everyone. That's a ton of information, and I can see the question bar going like this, so I'm sure that Angela has lots of questions that folks have been asking. I think that as a takeaway, I hope that the last 45 minutes or an hour have helped to at least make you be thoughtful that venous thromboembolism prevention is probably not a one-size-fits-all mentality, that our patients are different in their baseline risk for clots and the types of procedures that they're having. And as a result, we probably should be treating them differently. I hope that you'll consider implementing this and sticking this up on the wall of your clinic as a reminder that there are multiple opportunities that you have to identify and modify risk for clots. But to be fair, I clearly use the word modify, but never eliminate, because even with the best strategies, I don't think that we can drive our risk for clots to zero, but we certainly can make it smaller using a thoughtful approach. I appreciate everyone's time today, and Angela, I'll turn it over to you to take some questions.
Thank you. And as always, a very thoughtful and insightful, well described kind of approach. You looked at all the data, and we do have a couple questions. I'm going to try to unmute each of these people so they can actually ask their questions themselves, since we are on time.
Sure.
So let's see. First one is Dr. Ali still here? Ali.
Are you able to hear me?
Yes.
Okay. Well, thank you for as Angela said, a more balanced approach, because if you live in the world outside of maybe your immediate area or expertise, we're all just getting pressure to give chemoprophylaxis to everybody. So my question is, do you think that the mechanism or etiology of VTE in general is uniform? And I'll tell you, my opinion is they are so widely different, but we're treating them and preventing them all the same. And I just think that we're too far or too early to be able to discover all those things. There's obviously a lot of potential etiologies out there, and I just don't think that treating all of them the same makes sense to me.
Yeah, I think that that's a great point. I think that the trend, even over the last 15 years for VTE prevention, has really been moving more toward an individualized approach. We talked a lot about individualized risk stratification, acknowledging that procedure type alone does not dictate your risk for clots. And if you look at the 7th edition of the American College of Chest Physicians guidelines, they made their recommendations that you should provide, your prevention strategy should be geared by what procedure you're doing, regardless of the patient in whom it's being performed on. And the later editions, the 9th, really emphasize considering patient level risk. I agree with you that different operations definitely carry different levels of risk. And we know, for example, in cancer that pancreatic cancer, brain cancer carry a much higher risk for VTE than a breast cancer diagnosis. There's something inherent to those malignancies that increase your VTE risk over the regular or over different types of cancer patients. Things that we do in the operating room, I think, matter as well. Wallplication is a great example. And certainly, I think that Virchow's triad, even from the 1860s, still gets it right. There are different ways that clots start to form, to get really to your question. Some people may have stasis as their initial contribution. Some people may have hypercoagulability, a genetic predisposition. Some people may have intimal damage. And realize that surgery is not the only thing that puts people at risk for clots. There's a wealth of literature in the medical population, people who have never had surgery, and even medical people, and even people up and walking around get clots without surgery as a stimulus. So I completely agree with you that the inciting factor or factors are different in different people, and it's a great thing to think about. One thing that I did in 6 years at Utah is I ran 11 clinical trials looking at differences in enoxaparin metabolism by surgery type. And that's a great example of your question, is that when we use a one-size-fits-all strategy for how do you dose an anticoagulant, people metabolize that anticoagulant differently based on the surgery they had, both duration and how extensive that surgery was. It's just another paradigm where we can be individualizing our prevention strategy. Thanks for a great question.
Thank you.
Great. So our next question comes from Anna Schoenbrunner at Ohio State. Anna?
Hi, thanks for giving a great talk. My question is about patients with peripheral vascular disease. I've heard conflicting evidence that ICDs can either dislodge chronic clots in those patients, and I've also heard that they should be used. I'm wondering what your thoughts are on that.
Anna, just so I'm clear, you're talking about like established chronic deep vein thromboses as opposed to peripheral vascular disease, meaning arterial disease? You're talking about existing venous disease that's known?
Not necessarily for known chronic VTEs, but patients who come in just a sort of run-of-the-mill vasculopath who comes in, and this is more in a reconstructive context. Do you use ICDs for those patients?
Sure. I think that for people with known existing arterial disease, I don't think that there's any reason you couldn't, there's no crosswalk where IPCs are going to increase or change the risk for deep vein thrombosis. From a reconstructive perspective, there are places, I know Karen Kim Evans at Georgetown is one of the leaders in this area, who are routinely doing venous duplex to identify vein drainage targets, and they find that they are identifying chronically clotted veins in the target lower extremity that they otherwise wouldn't have known about. For those people, I think it really depends. I've talked with vascular surgeons about this, and for people who have a well-documented chronic deep vein thrombosis that is basically just an extension of the vein wall, vascular surgeons have told me that that is not at risk of being embolized because it's essentially fixed to the vein wall itself, and the only way to fix that problem is to put in like an expandable stent. For a chronic or for an acute deep vein thrombosis, one which is inherently unstable and has the opportunity to propagate, I agree with you that you might not want to be squeezing and potentially propelling that more proximally toward the heart into the circulation. Thank you for your question.
Thanks.
Great. Our next question comes from Nora Nugent.
Hi, great talk. Thank you very much.
Thank you, Nora.
I actually had two questions. First one was about the use of both compression stockings and intermittent compression pumps together during anesthesia and in the early postoperative period. We've been having lots of discussions about moving towards just using one rather than both, and I was wondering what your opinion was on that.
Mm-hmm. Sure, I can answer that one. So the two, in my mind, the two are, they do work through different mechanisms. The elastic compression stockings are designed to minimize blood pooling in the superficial system and to provide a constant external squeeze that we believe shunts blood from the superficial to the deep system and facilitates it getting out of the leg. The intermittent pneumatic compression stockings work potentially by increasing circulating levels of anticoagulants at a low level, but also physically propelling the blood out. So they do work differently. I'm not aware of any data that have looked specifically at using elastic compression stockings plus IPCs versus IPC alone. There is one Cochrane meta-analysis that the first author I'm blanking on right now, but they did look head-to-head on elastic compression or IPCs and showed that if you got to choose, IPCs alone are better for VTE risk, for DVT risk reduction than elastic compression alone. But I'm not aware of any data that have looked at the combination of the two versus either one individually. I think you had a second question?
Yes, my second question was a follow-up to a question someone else had placed higher up in the chat. The first question someone had placed was about your recommendation for flying home for out-of-town patients, how long you recommended after surgery. My question was related to that. Do you have a particular recommendation for patients out of town, long-haul flights, about the time they fly in before surgery? You know, how long a gap between arriving and having surgery?
Yeah, I think it's a great question. And I mean, the Lawnflit data that I presented, to be fair, were sort of the worst case scenario. They were passengers in coach going from Los Angeles to either Australia or Asia, if I remember correctly. So, I mean, these are 12 to 14-hour flights, overnight flights where people are not going to be well hydrated, not getting up and moving, and stuck in coach. The hour or 2-hour flight, there's no data on that I'm aware of. But there are good data that say that your risk for asymptomatic clots does go down with the compression stocking. So for people that are flying, for me, you know, both in Salt Lake and now in Spokane, you know, we have a 500-mile catchment area in any direction. Folks are often taking a 90-minute flight to come and see me. So even for those 90-minute flights, I'll ask people to wear the compression stockings, frankly, because I don't see a reason not to. I don't see a downside outside of the $20 purchase cost to have patients wear those.
Do you
body, I'm getting to your question as well. Thank you. Asymptomatic clots are difficult to be thoughtful about because, frankly, we don't have a lot of data on them. People develop asymptomatic clots, and your body will break those down without you ever realizing that it was there. So part of the danger of scanning people who have no symptoms is that you may identify a clot that otherwise was clinically irrelevant. So we don't really know the time course with which those break down if they occur. Your question is about how soon before can they fly in and how soon after can they leave. I don't have any data to guide that. For me, when I know people are flying in to see me, I would rather that they not have just gotten off the flight and come right to the office. And I'm always talking with them about getting up every hour on the flight, staying well hydrated, going to the bathroom, wearing their compression stockings. For me personally, and this is not a data-driven recommendation, but I would prefer that folks fly in a couple of days before they're going to see, like if it's for a surgery, that they be in town for a day or two to equilibrate. And on the back end, I would see people for their first post-operative visit before sending them out, and ideally keep them in town at least a week so that I can have some short-term follow-up with them, and also make sure that they're up and walking and well hydrated as well. But there's no data to guide that recommendation. That's just what I would think.
Thank you.
Thank you.
So the original question, I don't know if Dr. Stiles is still here, was how long do you ask them to wait before they fly home?
Yeah, and I think that's the same. There's no data to say it's 5 days, it's 7 days, it's 10 days. I think that there's great data out of the UK Million Women study that was published by Sweetland in 2009 that shows that after ambulatory or inpatient surgery, patients' risk for clot can remain elevated for 3 to 6 months. And knowing that it's probably not the flight that's going to be the final risk factor that gets added, but to make sure that someone is ready, in your opinion, to fly, that they can get up and walk regularly, that they're keeping fluid down and staying hydrated, is the best that I can tell you. There's not a data-driven guideline that's going to answer that question.
Great.
Angela, this is Dr. Stiles. Thank you for going back to that, and thank you, Dr. Pannucci. Because one of the other issues we see a lot with medical tourism is that patients will have pretty expensive surgeries, multiple areas, and within 5 to 7 days, all the drains are out and they're put on a plane to come back to the U.S. And, you know, I don't know if there's a way to assess their risk for DVT over our patients who are done here. But I was looking for just some general guidelines on when you recommend that it's safe for them to get back on a plane.
Yeah, I think that I mean, you're pointing almost to a larger issue in medical tourism, which is to say that the surgeon of record has minimal opportunity to follow up on those patients, and who then manages complications that occur. Because I think that we all appreciate that complications can occur 2 weeks, 3 weeks, 4 weeks, and at that point the patient is home wherever home is. And having seen some of those consults, it's difficult and frustrating to have no operative report, no records, and we try to be treating people blind. But I think it's a general problem with medical tourism for VTE and complications in general.
It can be tricky, always inheriting somebody else's mess.
Yes.
So I just wanted to share everybody, as people are having to log out. Next week, we do have Dr. Ali, who asked today's first question, talking to us about massive weight loss contouring. For the residents on Monday and Wednesday, we'll be having Greg Borschel talk about facial palsy or facial paralysis surgery. And then Wednesday is Dr. Neumeister, who was also with us today, talking about hand fractures. So next question comes from Johns Hopkins resident Akash Chandawarkar. I am so sorry. I did not say that right, I'm sure. Are you here? Oh. Are you here? Can you hear us? I can't hear you. Akash? If he's not here, I'll ask his question for we're having trouble hearing you, so I'll ask this question for him. He noted that there is a growing popularity of both topical and IV TXA, which is tranexamic acid, that's been shown to be safe in other specialties. Do you have a cutoff score where you think TXA might be contraindicated?
We have no idea. The TXA literature, I mean, my only knowledge of TXA is back when I was a resident in Michigan. I know that they were studying TXA in the craniofacial pediatrics population as a way to mitigate blood loss and trying to figure out, as well, is there any change in thrombotic occurrences as a result? But TXA is a totally new can of worms that I've seen used topically. I've heard of being used IV. I know the ortho folks are really excited about it, but there are absolutely no data to guide that recommendation. So no, I can't recommend a Caprini score at which TXA may or may not be harmful.
Yeah, I think there's a lot of unknowns currently about TXA. We're just starting to figure out, if we can safely do free flaps with people on it. And so, but I know of people using it for facelifts to, just why not, if you can just throw it on there, especially at a higher risk, male facelift or things like that.
Yep.
Yep. Well, I guess we'll have to kind of see. Next question is, this is a good one.
Angela, I'm looking at Phaedra's poll. Have you lost a patient to VTE? And of 96 people that have responded, 14% said yes. And I'm unfortunately in that group with the 14% of you. I feel for all of you because it's difficult. And Pedro, screenshot that because that's really incredible and disturbing, actually. It's something that I think that we all should know about and talk about, because this is not limited to any one of our practices. This is something that impacts all of us and all of our practices. So, wow. Angela, I'm sorry I interrupted you. Go ahead.
No, that's, we don't have too many questions, so it's good. But I agree. I am also one of that category, and I've had more than one since I do a lot of trauma reconstruction. So those patients obviously are high risk because of prolonged immobility. All right, next question is from Annie M. I don't know what her full name is. Annie, are you there to ask? Because this is actually a really great question. So if she's not there, I definitely want to ask this one for her. Let me see.
I'm unmuting her.
Yep.
Hi, Annie.
Annie has a little Elmo as her icon.
Can you hear me?
Yes.
Hey, it's Anita. I'm one of the residents at Mayo.
Oh, is this Anita Mohan?
Yeah.
Hi, Anita.
Hi, I'm Elmo on Zoom.
Okay.
Okay, so I just had a question. It was just regarding, you know, from your first statement in the talk about individualizing sort of practice, but we were trying to look and have discussions of this recently regarding enoxaparin dosing, because, you know, typically we just give that 40 milligrams once a day. We've had some higher risk patients, and I don't know, I was going to ask, do you have a protocol, number one, about sort of weight adjusting the dose for that enoxaparin? And, you know, there were papers in the literature showing that, you know, our typical dosing that we might just use actually is subtherapeutic in terms of even for providing any prophylaxis. So do you have any protocols in order to make sure that even if we are giving prophylaxis with enoxaparin, we're actually achieving a level that's giving any for those high-risk trauma patients or high-risk patients?
Yeah, those are my papers. Thanks for reading them.
Yeah.
6 years at Utah, this was one of my big pushes, was to look at the role of individualization of enoxaparin dose. You're correct that in a pharmacokinetic study that we did, looking at how people metabolize a dose of 40 milligrams once a day, we showed that the majority, 53%, I think, had under anticoagulated, and that people under anticoagulated were significantly more likely to develop clots. So we doubled that dose in a second trial and looked at the role of 40 BID, which brought our clot rate to 0 in 118 of your worst players, your inpatient trauma patients, but increased the bleeding risk to, I think it was 3% operative bleeding and 7% that required at least enoxaparin cessation.
So what would you, oh, sorry, I'll let you finish.
In review right now at PRS is the results of the 5 trial, which was a 2-year randomized clinical trial that randomized 296 patients at the University of Utah to a weight-based 0.5 milligram per kilogram dose or a flat dose of 40 twice a day. And I think that, well, I don't think that, I know that that study showed that a weight-based dosing is probably going to be the dominant strategy, at least as an initial guide for how you should be dosing it. So the weight-based 0.5 milligram per kilogram, what it did is it took the major contributor to how fast people metabolize that medicine, which weight is a marker for, and allows you to say, oh, your super tiny skinny person should get a dose of something like 20 or 25 BID. And your person might be better to start at a dose of 40 or 50 BID. So it remains an imperfect science. And once that study is hopefully accepted, it's still in review. I'll be excited to share it with everybody in a little bit more detail. But I think that just like the focus of the talk was care individualization, I think that individualization, even of your anticoagulant strategy, is a way that you can improve the risks and benefits of that medication at the patient level. More work to be done. Thank you for your question.
No, thank you.
And a very nice Instagram video recently. She and a bunch of Indian women plastic surgeons. I don't know if people have seen that on social media. They did the don't rush challenge. Next question is along the same lines. We got a couple questions about dosing, and so I'm gonna lump them together from D. Lups. If he or she is here.
Yeah, I'm here.
Yeah.
We work at VCU, and we have some patients from 600 Pound Life at the hospital, and I feel like maybe the weight-based dosing for a 600 pound patient is right. And we've actually consulted Hem-Onc about this, and they stuck with the per kilogram recommendations, and I was really skeptical about that.
Yeah, I think that so to be fair, for the clinical trial that we did, we capped the maximum weight at 150 kilograms, specifically because we knew that, you know, it takes a fair bit of sphincter to give somebody a prophylactic dose of enoxaparin 100 milligrams twice a day. I think for your really large people, to get an idea about how they're metabolizing the drug, that's a person who you might start with not a 0.5 milligram per kilogram dose, because in a 600 pound person, that's unreasonable, but start them at some higher dose, and maybe it's, you know, 60 or 70 BID, but be following anti-factor 10A levels to make sure that you're in the right range. You'll probably underdose it on the front side, which is okay, and then you can ramp it up with the guidance of your inpatient pharmacist once you do that. I think the 10A levels are a great way to demonstrate the impact of your intervention. You're not just saying I'm giving enoxaparin, you're saying I'm giving enoxaparin and I'm showing that it's actually doing what I want it to do.
That's really helpful, because we've had some patients that were obese that were probably overdosed that have bled.
Yeah, and for those morbidly obese people, I think you have to think outside of the box. And talking with your pharmacist, you know, the pharmacokinetics it peaks 4 hours after the third dose. So that's when you should be drawing your levels. And I think to have a regular conversation with your inpatient pharmacist to say, help me to optimize this dose for this patient that's not a standard patient, would be the right thing to do.
All right, thank you.
Sure,
That's great. That was Ryan Eubanks' question from Wayne State. It was like, do you get anti-factor 10A and adjust? So absolutely. I mean, our patients are only getting bigger and bigger and bigger, and it can be such a struggle. And you do wonder what's worse, having them bleed to death or having a clot. So especially, you know, we're doing big cases and these, you know, 12-hour free flaps sometimes for bilateral breasts, you know, BMI 52. It's just hard to reconcile. Next question comes from Adam Franklin from University of Oklahoma. I think you kind of touched on this earlier, but I'll let him ask anyways. Oh, no, Mike. He wants to know, how long do you treat your anticoagulation post-op patients, these high-risk ones, and what do you use?
Yeah, it's a great question. The best data that I have to answer that question is to say that the VTEP study provided patients with inpatient anticoagulation for the duration of their inpatient stay. And that was it. And in that study, we were able to show that high-risk patients did have a benefit. If you take the other end of the spectrum, there's randomized control data for high-risk ortho, hip, and knee, for high-risk abdominal and pelvic cancer, that shows that an extended duration of prophylaxis out to 28 days is better than a 7-day course. And to be fair, that's for all-cause events, symptomatic and asymptomatic. So those people were routinely being screened in order to identify your outcomes. There are no data to say how long you should be treating your patients for. I think that for your inpatients, the easy answer, because it is data-driven, is at least is the duration of their inpatient stay. You as a surgeon have the discretion to sort of envision, how is this person going to do at home? How are they going to be up and moving? And should I be giving them post-discharge prophylaxis? I do not routinely provide post-discharge prophylaxis to everyone. I do it on a very selected case-by-case basis in probably 10% or less of my people. When I do it, for example, if I have a high-risk ambulatory patient, I think of a woman that I've taken care of who had a breast cancer. She had a port-associated deep vein thrombosis. She had a factor V Leiden mutation, and she was having an outpatient breast revision with me. And for her, I sent her out on, I think it was a 2-week course of enoxaparin because that inherently made sense to me. But there are no data to guide your choice of anticoagulant and the duration. For me, what I would personally do would be, if I'm going to do it after discharge, it's going to be a 1 to 2 week course. If you have someone who is super high risk or is at lower extremity trauma, free flap, in bed, multiple other injuries, the trauma surgeon may want to send them out on a month anyway, and that wouldn't be unreasonable. But unfortunately, it becomes surgeon discretion. There are no data to guide that in plastic surgery.
Great. I know it's frustrating, right? That's what we need from you next. We need that paper.
Sure. Taking notes. I'll write it down.
So our next question comes from University of Toronto, from Moath Sagaf.
Yes, thank you. Thank you for the great talk. I wanted to get your thoughts on certain institution not scanning with ultrasound for DVTs below knee. They only scan above knee, thinking that it might not be clinically significant and not require treatment. And I was wondering if the studies you featured in your talk were actually accounted for that in like their analysis.
Yeah, I think that in a larger perspective, your question is about the relevance of calf vein, deep vein thrombosis. You know, I attend the National American Venous Forum meeting because I'm interested in clots on a regular basis. And every year there's a panel about how to manage calf vein DVT. And the recommendations, even amongst panels of vascular surgeons, are split to say this is a relevant or irrelevant finding. Some people will just get a repeat duplex at a week to make sure that the soleal vein clot or perineal vein clot hasn't extended to the popliteal vein, and they won't anticoagulate at all. Some people will say this is a deep vein thrombosis and it should be treated with at least 3 months of anticoagulation. I mean, I talked about probably 20 or 25 different studies during my talk, and I think that how they define deep vein thrombosis was probably rigorously defined in the paper, but I can't specifically say what each of them used as their cutoff. I believe that calf vein clots are real. I believe that calf vein clots should be treated as clots and not ignored. That's my own personal opinion, but you know, for me, if I have a patient who gets diagnosed with a deep vein thrombosis, I still call a vascular surgeon, because at the end of the day, I know a lot about clots, but I still want their input because I don't manage the long-term ramifications of deep vein thrombosis, like the post-thrombotic syndrome and chronic reflux. And the vascular surgeons almost always are interested to talk with you about your patient, but have something to offer. So I very regularly involve my vascular surgery colleagues when clots get diagnosed, and I don't just brush off a calf vein diagnosis as that's not a big deal.
That's helpful. Thank you so much.
Thank you.
Our next question comes from one of my Emory residents, Amir Razavi.
Hey, hi, Amir.
I know how to say that name.
Thank you for the great talk. Hopefully you can hear me. Wanted to ask about, you know, we have now more and more data coming from general surgery, colorectal surgery, about use of preoperative single dose of either heparin or Lovenox prior to induction. I want to see what your thoughts are on essentially in high risk or combined cases, the use of preoperative dose of.
Yeah, I think that the original way that enoxaparin, for example, was used was to start that dose either the night before or basically on call to the operating room. In the original randomized control trials, like the enoxacan studies that were published in the early 90s, that was the regimen they used, a really aggressive regimen. One of the papers that I put up in the talk today was the facelift paper from Austria, excuse me, that gave preoperative dosing in facelifts, and 16% of people had a bleed basically in the PACU. So we also looked at this when I was part of the AAPS systematic review, and we specifically looked for papers that started the dose pre versus post-op, and we couldn't show that there was a distinct benefit to providing that first dose prior to surgery. And based on that, the AAPS's recommendation was actually that post-operative dosing is the data-driven standard that we can recommend for plastic surgery patients. That being said, for my free flaps, I will sometimes give a dose of subcutaneous heparin or right before the microvascular anastomosis, intravenous heparin. But for me, that's a microvascular patency question that may have an effect on their risk for DVT or PE. But I'm not giving a dose of pre-op subcu heparin or intravenous heparin. I'm not giving that because I'm worried about their DVT risk. I'm giving it because I want to be thoughtful about microvascular patency when the clamps come off. For me, that's the only time that I use intraoperative dosing of heparin, subcu or IV.
On that note, I'm going to interject one question before we get to Sarah's. The data is kind of mixed on tamoxifen. So do you hold that before surgery?
I do. I look at, I group tamoxifen in with oral contraceptives and other potentially modifiable risk factors.
Okay.
My personal preference is if we know that it increases risk, and unless their oncologist says there's a distinct harm that's going to occur by taking it off, I do it 3 weeks before and 3 weeks after.
Perfect. All right, next question comes from Sarah Idelson.
Hi, Howard, can you hear me?
Yes.
We can. Hi, Sarah.
Hi, I'm a general surgery resident calling from University of Miami. So I was just wondering, with the increased use of TEG across hospitals now, do you see in the future at all any room for us doing perioperative testing, especially in those patients that are higher risk?
Yeah, so TEG is a new, it's certainly a newer paradigm in plastic surgery patients. It's probably less new in the trauma surgery literature, but TEG is, in my mind, similar to anti-factor 10A. It's a way that you can understand your patient's propensity to clot and potentially to tailor an anticoagulant strategy to that propensity to clot. So I think it's a neat idea. I have no experience using it, but I think that it's one of those things that if someone wants to champion it, if someone wants to figure out how it can be useful on a day-to-day basis, I think that a lot of big hospitals now have TEG. And so if someone wants to champion it and figure out how it can be useful in our patients, a lot of us would probably love to know, but there's no data that I'm aware of specific to us right now.
I know it's come a long way. And when I did general surgery and trauma, we'd get it and then we're like, okay, so now what?
So now what, right?
Right. The answer is still give platelets, give FFP, give something.
Right.
All right. Next question comes from University of Iowa, Ali Abtahi.
Yes, sir. Thanks for this wonderful talk. It was fantastic. Really enjoyed it. Wanted to ask a question regarding HIT screening. My institution has a institution-wide policy to have mandatory preoperative or pre-hospital platelet levels or platelet levels drawn the first day of admission before administration of heparin, and then regular platelet levels drawn to screen for HIT, and while a patient is receiving any type of DVT or chemical DVT prophylaxis. What are your thoughts on that?
That's a very aggressive strategy that, from an external perspective, feels like it was driven by one or two bad outcomes, and that their response was to make a hospital-wide policy.
I agree 100%.
I'm not aware of any other major institution that has put HIT on so high of a pedestal, and certainly much higher than other, genetic hypercoagulable states. The risk for HIT, to my knowledge, is like 1% or some very low percentage of people who are getting heparin. And, when you think about it differently, like 5% of Caucasian people have factor V Leiden. So if you're going to screen for HIT, should you be running a genetic hypercoagulability panel on everybody? I think both would be incredibly aggressive, and I don't routinely screen people for HIT before putting them on an anticoagulant for sure. But if the University of Iowa is, I hope that they'll look at those data and publish them and say, this was a cost-effective intervention, this identified people with problems more often than not, or justify it in some way.
Thank you, sir. I agree wholeheartedly.
Seems like some administrator just, made unfortunately, that's what we deal with a lot of times in medicine, right? One bad thing happens, we have like a rule or a policy, and you're like, what? And we're all stuck with it. All I think that is it. Anybody, if I missed anybody, shoot me a chat right now with all the questions. Those are great questions. I think, you know, a great discussion always leaves you with more questions and things to be answered. Sometimes it's a talk, and we certainly generated a couple more questions, everybody. And, you know, hopefully we'll figure this out as we move forward and what the best thing for our patients is, because this is a difficult topic. And for those of us who've lost patients to this, you know, you just never want to see it again. If you could do something to prevent it, it's just, you know, something that eats at you a little bit. So I guess in some sense, I'd rather deal with the bleeding, right? So it's great. Thank you again for your time, Dr. Pannucci.
Great.
And we hope your practice gets going again soon.
Oh, yeah. Well, COVID-19,
Angela,
less busy.
Angela,
yes.
Angela, this is Fuad. Just wanted to thank Chris for an incredible presentation. I was familiar with almost all the papers you cited, especially those from ASJ. Despite that, I learned a lot. I just asked Phaedra, our executive editor, to text the information on a paper that we wrote on the risk of VTE and facelift. And just to let you know, at the risk of you having chastising me, I've operated on 5 patients with Leiden factor 5. I've done facelifts on them without anticoagulation. Thank you for doing this. Angela, thank you for stepping out of a free flap to run this. I'm sure that Bill has done a great job in your absence.
Oh, Bill's doing this, and now the residents are flipping. The residents are flipping the patient with the free flap dangling. It's great. All right, well, we'll see everybody next week. The Friday session is Dr. Ali. If anybody's still missing the links, just email Phaedra, but it should be the same as for today. And we'll wish everybody, I know some places are starting to, like Georgia, starting to ease up on surgery, so wish everybody luck getting back in the OR.
Great. All right, thank you, everyone.
Thank you.